Our next speaker is Dr. Alain Romanos. Alain is the assistant professor at the postdoctoral program of periodontology at the Lebanese University and serves as visiting assistant professor at the University of Alabama, Birmingham. So he's also adjunct faculty in the Department of Perio at Savita College in Chennai, India. He received his DMD from Free University of Brussels, Belgium, his certificate in AEGD, Advanced Education in General Dentistry, certificate in Perio and Masters of Science from Alabama, Birmingham. He's a diplomat of the American Academy of Periodontology. He loves teaching and lecturing. He's published many articles in periodontics and the dental implant field. He gave more than 200 seminars, courses, and webinars on soft tissue, perio, and implant surgery, nationally and internationally. I present to you Dr. Alain Romanos.
I'm going to stay down.
Thanks. Stay down here.
Yeah, sir. Thanks for this nice introduction. Where did you get all this info from? I didn't know. Thanks. Okay, it's lunchtime. I know some of us probably are hungry. Thank you for this kind invitation. It's a great honor to be here with such a prestigious group of speakers, my friend Howie, Ricardo, Bassam, Imad, and the rest, Raquel. It's really amazing. It's a nice program. Thank you, Ritter, for putting this together. Today, my topic is about complications, and specifically, if you receive some implants that are not positioned in the right place, in the right 3D positioning, how can you manage these cases? How can you save these cases? So technically, this is what we will be talking about. So this is the topic of the menu for this session for the next 50 minutes. We'll talk about the risk factors, why people get to place their implant in a bad 3D positioning. How can we prevent this? And the best treatment for complications, my friend, is to prevent it. 3 is how, if you receive these cases, can you manage them? Is it possible to manage some of these cases? And we will take some messages back home. So if we do a little search and just go on Google and try to see how many implants are placed worldwide, there's numbers, it's not accurate numbers because, many companies, you cannot list them, many copies, but the average is about 8 million implants are placed worldwide. 3 of them in the US, 3 of them in Europe, and 2 in the rest of the world. And these numbers tend to increase. So we have to expect more implants to be placed, and they're expecting almost 23% in 2026. So if you're a practitioner today and you're placing 100 implants this year, so you have to expect next year to be placing 120, which is, very logic. The business grows and so on. So the more implant, my friends, we're going to place, the more complications we are going to receive. And you have to expect to see these patients walking into your practice. And sadly, I'm seeing these cases on a weekly basis, whether I'm at the school where I teach or at my private practice. And I can tell you, these patients, they come with a, mental impact. It's really destroying them emotionally because they've been through surgery, they've been through, many years of treatment, and the end result is, not really satisfactory. And the next wave of complications, my friend, this is a tsunami today, is the peri-implantitis. If you look at the numbers, at 5 years, we're expecting 20% of the implant that we're placing today to get some peri-implantitis issue. So the question is, can we avoid all this? Can we minimize or lower our number of complications? Is it possible to, be predictable in our practice with our patient? And sadly, we looked at the small study that we did at the university. We looked at Mkizi. Okay. We looked at 324 cases, and we looked at these complications, and we tried to understand what was the reason of this complication. And guess what? The number was 80% behind these complications were the practitioner. So we are causing harm more than, biology. And when you look at the reason why are we behind these complications, And you try to look at the literature. Is the surgeon as a risk factor for complications? And yes, we found 2 articles in the literature that support, if you're a beginner or if you have no experience, chances that you're going to have a complication 6 times more than somebody who has experience. So, education is very important. Knowing what you're doing is really important as a surgeon, because this will affect our reputation. This will affect our name in the medical field, and plus with the insurance companies and so on. So today's patients are different than patients 10 years ago. Today's patient, they come to you and they tell you, hey, I have a black hole here. I need to fill this papilla. Today's patient, they come and they say, I have a recession. Can I treat this recession? Many years ago, nobody even noticed about recession. So today's, if you looked at patient-centered studies, the perception is different. So therefore, we have to be really, accurate, and we have to be predictable with what we do. So the question is, why do we have these complications, and what is the main risk factor, and what are the etiological factors for these complications? Well, in implant dentistry, Howie taught me there's 4 pillars. One of them is related to soft tissue, and soft tissue is always the issue. And Ricardo spoke about this. So soft tissue, and if you look at the studies that support the need for the soft tissue in terms of keratinized tissue or thickness or width to support implant, this, it's a heavy level of evidence that we have today in the literature. But the sad story is what? What's the sad story? 50 to 70% of our cases, they come to us with the lack of attached mucosa around these implants. 50 to 70%. 33% just, they have a color match. So you place one implant in the aesthetic zone, 33%, they match with the other teeth. 70%, people don't show you this on the screen. Not us, other speakers, of course. So, people show you the best case. But the reality, my friend, the numbers doesn't, these are studies. So there is still lack of issue with the soft tissue. The second, pillar for aesthetic dentistry is bone. You have to have the bone. You have to support, your implant with bone, whether it's a horizontal or vertical. And most of the time when I placing implant, I never see an intact buccal bone. I always have some deficiency, whether it's a V defect or a W defect or U defect, and we have to manage these defects. We, as a surgeon, we have a buccal defect. We cannot just ignore it. We have to do some guided bone regeneration techniques to restore this bone defect. The third pillar is the prosthesis. And of course, I will not talk about the subcontrol Ricardo did, but we have to respect, the guidelines when it comes to choosing your abutment, choosing the right design, choosing the right, shape of your temporary, from temporary all the way to the final prosthesis. So prosthesis, you do all the surgeries, you place your implant right, you do the bone graft, you do the soft tissue graft, but the prosthesis has to complete what we achieve surgically. And the number 4 pillar for implant dentistry is implant positioning, which I will be talking about. And today we have guidelines. When I started doing implant dentistry back in 1999, we did not have any guidelines for implant in the aesthetic zone. We were placing the implant where the bone was. But today we know. We know today where is the most safest zone to place these implants in an ideal 3D position. So we get to the second point now, the etiology. Why do we have these complications? Why we place our implant badly? And obviously you have three positioning when it comes to placing your implant. In these 3 positions, we will try to see how we can prevent this from happening. So the best treatment, my friends, the best treatment for complications is not to have it in the first place. And how do you prevent this from happening? Well, if it's an advanced case where you have an advanced bone loss or a soft tissue loss, just stage it. Don't try to do everything immediate. There's some cases we can still, we like to do immediate. Of course, this is our primary goal. But there's some cases, probably too many miracles at the same time, it's not very recommended. So we just stage it. Some other cases, well, today we have, in-house lab, we have a printer. Today the printer, this guide doesn't cost us much, $3. That's it. And it saves you so much time and so much, stress. It guides you. It guides you to place your implant in an ideal 3D position. You just have to do the right planning. You have, especially if you're doing immediate, because it's very challenging when you're drilling to the palatal bone, the drill push you to the, to the buccal side. So you have to fight against this site. So here, it makes things really easier. And today the technology is super, safe. And if you do the right planning and you do the right guide, you can place your implant in the right position. Number 3, soft tissue. In case you have a thin biotype, and what I mean by thin biotype, if you have less than 1 millimeter tissue thickness, less than 1 millimeter of tissue thickness, if you don't have a keratinized mucosa, if you don't have an attached mucosa around these implants, please, it takes you 5 to 10 minutes. You have many techniques. You can graft it as a connective, you can place it as a tunnel if you wish, or you can do it at the second stage as a free gingival graft to support your prosthesis. One of the biggest risk factors for peri-implantitis is the lack of keratinized mucosa. So, why you want to take the risk to see your patient in 5 years with food impaction, pain, sensitivity, bone loss, if you don't have this attached gingiva. And today you have the palate, this is really, it's amazing. I'm a tuberosity fan. If people knows me, they know every time I see a patient, I say, hi, how are you? How you doing? I take my finger and I put it on the tuberosity. This is the first thing I do, right? So if you come to Dubai here or to Lebanon and you meet people on the street, they have no tuberosity, probably I'm the one who took it. So tuberosity is really my number one area, but there's a disadvantage. I'll tell you, how you know what is the disadvantage of taking the tuberosity. It's quick, it doesn't take time, it doesn't hurt, and it's available. For single tooth, it's amazing. Well, if you don't want to take tuberosity, you can take the anterior palate or the posterior palate, or you take a single incision depending on the thickness of the palate. So really, this is nature. This is a human, the patient's own tissue are still today the best tissue. And then you have the bone. And, in cases, and I'm seeing more and more of bone loss. And you know why? And we know why we're doing more and more GBR and vertical bone augmentation, because we're removing so many implants. And when you're not just removing the implants, you're removing the implants and the bone with it. And we all have peri-implantitis. When you see the cases of peri-implantitis, they're losing bone and soft tissue. And you have to reconstruct again all these cases from the beginning. And imagine the time, the money, and the psychological effect on our patient. So this is really important to have all these on board before you place your implant. Bone, soft tissue, implant placement, prosthesis. 4 pillars for aesthetic implant dentistry. Now, if you have these complications, can you manage them? And what can we do with these cases? So I'll share with you some of these cases. Most of them are more than 10 years treated. So you have a long-term follow-up to see what happened to these cases. The most common complication I see today is deep implant placement. And one of the speakers touched the point on that. And the reason why surgeons today place the implant too deep. And I always ask people when I'm giving my courses, how deep the implant should be. And I hear so many different answers. 3 millimeter from the bone, 3 millimeter from the CJ, 5 millimeter from the contact point, 7, numbers, just numbers. Implant, like Nilesh said, implant is a surgical procedure driven by prosthesis. Where is going to be your future prosthesis? This is where you're supposed to place your implant. 3 to 4 millimeter from your future gingival margin, done. If there's bone, fine. If there's no bone, you have to graft the bone. When I was a student, they used to teach me, place the implant where the bone is. No, wrong. We have to place the implant where the final prosthesis will come. And the reason why surgeons place the implant too deep, because if they're doing immediate loading, they're keeping on pushing the implant to get a high torque, so they have a primary stability. This is reason number 1. Reason number 2, lack of experience. And reason number 3, if you're young and you're placing your implant, you're scared that you're gonna have some bone loss and you're gonna have some bone remodeling, and you don't want the titanium to show. So what do? We keep on pushing our implant too deep, right? And this is the common mistakes that we see in today's implant in the aesthetic zones. So placing implant in the coronal apical positions, my friend, well, there's a strong evidence in the literature. The deeper you place your implant, the more complications you will have, whether it's prosthetically, imagine the jumping distance from an 8 or 9 millimeter implant to get the right abutment with the right profile. And Ricardo just spoke about this morning. How deep, the deeper how are you gonna clean? How the patient is gonna clean? This is at 8 times more risk for peri-implantitis after 5 years. So imagine, we're placing the implant today and you're gonna see this patient in 5 to 10 years. So, this is unacceptable in today's implant dentistry. This is a surgeon, a friend of mine, oral surgeon that I work with. He usually places implant in the posterior zone and he referred me out the aesthetic zone. That case, I was out of town. So he had to place the implant himself. And then he sent me the case after a few years. He said, Alain, I have this patient. She's having pain, pus from this lateral. And when I took an X-ray, I was like, look at this. Look how deep is the implant. I mean, this is like 8 or 9 millimeter deep implant. Implant should be here. So we have a deep implant placement. And always when we have a complication, you have to come up with a list of etiology. So what are the main players here? And why do we have these issues? So we come up with our list. What are the challenges? And we try to find for each challenge the solution. Well, in this case, we have a deep implant placement, right? We have some interproximal bone loss, a partial loss of the papilla. We have a thin tissue, no attached mucosa, and we have a bad prosthesis with a pink porcelain over contour prosthesis. So we take each of this problem and we find solution for all of them. Now the question is, what are our options? Well, we can always remove the implant, but trust me, most patients that they come to see you, they would rather not to remove the implant. And all the cases I will show you today, patients didn't want to remove implants. They want to try to save it if they can, because they don't want to go through this experience, taking the implant again, adding bone graft, doing soft tissue. This is too much. And we try to increase the quality of the soft tissue and grafting papilla. So this is what we did. We first removed the crown, remove all the pink porcelain, the over contour, and look how deep this implant has been placed. We place bone? Yes, we place bone. Is this gonna turn into bone? I don't think so. But why do we do it? Well, I feel good to take bone just so I can sleep better at night, but this is probably gonna support my soft tissue. And then of course, we take the soft tissue because this case did not have any attached mucosa. So I took an anterior palate, split it in a 2 mesial and a distal papilla. So we cannot try to do today customized connective tissue graft, not one connective tissue graft that works on all of your patients. And we did the double papilla flap incision. Oh, just to keep you awake. Can we lower the? Can we lower? Okay, that's it. I want to wake them up, but not traumatize them. Right, Rachel, you traumatize them. No, just kidding. Okay. So this is what we did. We first started by removing the over contour of the crown, and then we did the double papilla flap on this case. Okay, we did the double papilla, and then I try to go to the tuberosity if I can. If not, if there's a lack of quantity, then we go to the anterior palate. The thickness should be always between 1.5 to 2 millimeter if your goal of treatment is tissue thickness and keratinized mucosa. And we always de-epithelialize this free gingival graft in order to have a good quality collagen hyperplastic tissue to cover the titanium and to hide the titanium implant. And here, this is after we clean the granulation tissue, double papilla, we suture first the 2 flaps together, and then place the bone connective and close. And then I lost this patient. She traveled to Australia. Everything was okay. I was happy, by the way, that she left the country because I, didn't know if this is gonna work. This is 2012, my friend. 2012, there were nothing in the literature, case reports. And then I learned this from Dr. Mish, where he did the tongue, mesial and distal papilla to try to graft these papillas. And she came back after 3 years. And then after 3 years, I was like, big relief, really. It did work well. with the same crown that I performed, and look at the soft tissue volume. It kept on growing, and we will talk about this in a minute. When you use the tuberosity or you use the free gingival graft converted into connective tissue graft, you have to expect that these tissue continue to grow. Sometimes it's good that you want them to grow, but some other times it's really, aesthetically, it's not really interesting because they are really hyperplastic and whitish. So this is the case after 3 years, everything looks good and stable till today. Another deep implant placement. This is a recent case, but I learned a lot from this case. This patient, she came to see me first a few years ago to treatment plan this lateral. And this is how she presented. She presented with this failing lateral incisor. My treatment plan was to do socket preservation. I told her we cannot place the implant immediately because, you know, you're losing bone, you have no interproximal bone here, so probably we have to stage the case. Let's do bone graft, soft tissue graft, wait, come back, place the implant, wait, come back, remodel the soft tissue at second stage, and then final prosthesis. But she felt I was too expensive. So she did go to see another dentist, and this other dentist placed this implant, and she came after she placed the implant and the crown. And she told me, you know, I wish I heard from you, but now I'm back. And I was like, listen, this is gonna cost you more than what I costed you the first time. So she was like, it's okay, I learned my lesson, I wanna do it. And I said, you know, I felt bad because she's a nice lady, she did not have the means. So I said, listen, I'm coming to Dubai in February, where are we today, 6th, giving a lecture. So I'm gonna do the case, just so she you know, to let my friends see the case, what's gonna happen, if I can fix this, okay? This implant is really badly placed. And when you look at the implant placement, too deep, too buccal, and really the interproximal bone, you know, we had to restore the bone on the adjacent tooth in order to have a good aesthetics. And the reason why you have no bone, well, she lost the bone in this first place. So when you look at this, we have to create bone here first on the interproximal to support the papilla. Otherwise, we're gonna end up with a short papilla. So I said, well, listen, let's try to save this case, even though I think we should remove it. Because once you open up a flap, and the other good news was she's a gummy smile. So you can play a little bit, you know, by bringing the tissue down from here, up from there, so maybe we can show you an illusion of a good aesthetic outcome. So gummy smile is good. Thin lips is good, you know. Raquel, we can always do fillers for these lips and drop the tissue down and you can't see anymore the complication. Or even Botox, you know. So anyway, once you remove the crown, you can see this implant is placed not just too deep, but too buccal as well. And tissue is becoming thin, of course, and what dictates whether the papilla is going to be present or not is not the bone on the implant, it's the bone on the adjacent tooth. So this case, you know, we knew that we have either to remove the implant or to attempt to do a graft and, you know, choose the right abutment with the right crown and do aesthetic crown lengthening on the other side. So this was my treatment plan. Advanced surgery. First, when you looked at the issue, the list of issues, and you start treating them one by one. Bad prosthesis, you remove the prosthesis. The best connective tissue graft that you can do today is nature. Just let it heal. We all surgeons, we all love soft tissue. We all want to do graft, you know, soft tissue graft. But sometimes, you know, if we stage it, if we take the time, sometimes let the nature do it for you. This is just by removing the crown and placing the cover screw, and then just by placing the cover screw and keep watching this, Howie, in 6 weeks, look how we went from nothing to this in 6 weeks. In 6 weeks, my friend, no graft, just it did fill in. So just, you know, by removing the bad crown, by removing this bad temporary and let things heal, this will come down, and it did come down. And Giorgio here, the prosthodontist, was helping me guiding the tissue with the temporary. So we always add, remove temporary just to bring the tissue down. Now I have a good condition to do my graft. I have a good quality soft tissue, and now at this point, it's a more predictable procedure to do the connective tissue graft. And this is what we did. So we removed, look at the implant. There's no thin buccal bone, buccally placed, too deep, Maybe, this is better to remove the whole implant and start all over again. But I decided just for you to try to save it so I can show you what will happen. So this is what we did. I took 2 tuberosities. She's not just have gummy smile, but I'm lucky that she has a good 2 tuberosities. And then I took them both and tried to do double graft, like buccal graft and palatal and papilla graft, which is really not easy. It's a very challenging procedure, I can tell you. And if I tell you it's predictable, it's not. I promise you, it's not. I have cases where I did 3 surgeries, tried to grafting the papilla. Papilla is my thesis. This is what I did. I did, my thesis on papilla. And it's not predictable surgically to graft papillas. And this is 6 weeks post-op. We connected the abutment, and look how deep is the implant. This is the longest abutment that the company had. So even with the longest abutment that they have, so we have to do some customized jumping abutments just to try to get to the head of this implant. And then what we did, we start to remodel the soft tissue. I was still not happy a lot with the final result, but it was acceptable, not perfect. And then, I did publish back in 2012 an article on filler, injecting the papillas with filler. And at the study that we did, it was a 50-50. 50% of the time we were predictable, the other 50% we were not. And, I felt like this is a good case because she's a partial papilla. So we didn't have a full papilla. We did not have a missing papilla. We had a partial papilla. In these cases, sometimes the filler works. So we did fill this on a multiple appointments, 3-4 sessions, and we were able to drop the papilla just a little bit. Not completed yet, but it's an acceptable result. And you have to expect when you have a complication, you cannot aim for 100%. You always have to aim for, 70, 80% of improvement. And this is where we got today with this papilla. So another one, what if you place your implant too shallow? And, placing the implant too shallow, this is really in today's implant dentistry is a malpractice. This is a patient, she came back in 2012. She had this implant placed, a shallow implant placement. And this lady, she has a social media company. She has 3 million followers, okay? So imagine the stress, worse than a lawyer, right? Because if you do something wrong here, your name is gonna be on all the social media platforms. And I didn't wanna really treat her because this is a high smile line, gummy smile implant. If you look at this, there's an attachment loss on both sides of the implant. This is nothing, this is not gonna work. I felt this is the case that you cannot really achieve a good result with the treatment. And what I proposed to this patient, I said, listen, the best thing to do, probably do crown lengthening and do veneers on all your teeth. So just by bringing the tissue on all the other teeth to the level of the implant, and probably do veneers. And Bassam, my friend, advised me to do the same because doing a connective tissue graft here, it's really not predictable. She said, no, I don't want to do veneers. I was like, okay. You don't want to do veneers. Tayyip. What are we going to do? This implant is really badly placed, too shallow. External connection. At the time, when you use an external connection, what do the connection between the implant and the abutment, there's a gap. And you always have, with these type of implants, some bone loss. You always have this suturization effect. Plus, the bone is not lost just on the implant, you lost the bone on the adjacent teeth. So the issue now is not just the implant, but the central and the canine. And trying to remove these implants back in 2012, we did not have the tools that we have today. You have to remove the implant and the bone with it, and you will affect the bone on the adjacent teeth on a patient that has a social media company. Are you gonna do this, right? It's, very stressing. So I was like, okay, listen, we can try. I cannot promise you, but we can try to graft the papilla. 2012, nothing in the literature, case reports. I was like, we can try. But this is gonna require 3 surgeries. How he taught me this. Always say 3 surgeries as a touch-up, okay? And the touch-up is when you fail. So you have to redo the surgery a second time. So I told her, this is 3 surgeries, ma'am. Do you wanna do it? Are you sure you wanna do it? She said, yes. Actually, at the time, I gave her the price that usually I charge 5 times more because I don't want her to do the case with me. And she still accepted. And I was like, shit, I can't get rid of this patient. And, the level of stress, I can't, even when I think about her now, look at me, I'm all shaking. And the night before the surgery, doctor, I swear I did not sleep the night before, I swear. I was all night, my eyes were, because I was so stressed. Okay, you've been there, right? Okay, good, I'm not the only one. So when you look at this, 2 shallow implant placement, external connection, interproximal bone loss on the central and the canine. So this is the worst case. This is a case that you should remove the implant and start all over again. Or do overlay. So the challenges here are what? Well, shallow implant placement, bad implant choice, external connection in the aesthetic zone, not too recommended nowadays, loss of interproximal bone, and bad prosthesis. And so we always try to look at the challenges and come up with the right solutions. And what are our treatment options? Well, you can always remove the implant, but we don't want to remove implants today. We can try to put the implant to sleep and then do like an overlay or, Maryland bridge. Again, she didn't want this option. We can attempt, and again, I say we can try because this is not predictable. And people who are grafting papillas, they're doing maybe 3 or 4 surgeries, waiting 2 years to get you to the result. This is not a predictable procedure. But it can be done in some cases, and choose the right abutment and design. And this is what we did. So we removed the crown, took the anterior palate, harvested, converted into connective tissue graft, put the implant back to sleep, so place with cover screw, and always use a sterilized cover screw. Don't use an old one or a non-sterile one. And then, because it happened to me once and it got an infection, so use always a sterile one. And then this is what we did. If you have to drop a vertical to make things easier, you can, but this is what we do, all right? طول السهرة امبارح. كتير سهرت امبارح. Coffee? No? So this is what we did. We try to keep the papillas if we can, and then we stretch the tissue to move everything coronally because we're going to put this implant to sleep. So if we're planning to put this implant to sleep, you have to have a passive suturing on the top of this implant. So here we flap everything, take the connective tissue, place the connective tissue, same technique, harvested, free, converted into connective, place it in 2 dimensions, vertically and horizontally, because we're trying to gain volume, not just in 1 dimension, but we're trying to gain volume in vertical and horizontal dimension. So this is after we take the connective tissue graft, we go forward, place temporary cemented on the adjacent teeth away from the gingival margin, and then 6 months after we start the remodeling phase. 6 months after, she was happy with the result. She didn't want to go. She felt I was Superman because in 1 time surgery, didn't have to do the touch-up. So lucky me, I was really super lucky in this case. And this is the case before or after. And then we had the crisis in Lebanon and she left the country. And I was so happy that she left. She moved to Saudi Arabia. She opened her company there. And then she called me up. She was coming for holidays to Lebanon and she called me up. And I said, I need to come to see you. And I start to stress out. I was like, everything okay with the implant? She said, yeah, everything okay, but I have an issue. And I said, what's the issue? She said, I feel that my tissue is growing, like I have, some tumor under my lip. And I was like, what? Tumor under the lip? Howie, this is your case. She came after 2 years, and then she was like, she felt this tissue is keep on growing. And big mistake, don't do it. Big mistake I did. I said, don't worry, it's okay, super easy. What we can do, take the laser and plastic this out. Don't do it. I took the laser, and Howie taught me this. We met in the AAP. When you use a free gingival graft, especially if you use it from the tuberosity, you have to expect some hyperplastic-ish tissue and then overgrowth over time. So you have to choose the right graft for the right patient, depending on the patient. So this is what I did. I did remove with the laser, big mistake. What happened afterward? Too wide. So because you're removing the epithelium, what are you exposing under the epithelium? You're exposing the free gingival graft, which is very collagenic graft. And then she left the country again, came back last month, few months ago, in December. And I said, please, can you come for a picture? I'm coming to Dubai. I want to show my friends here at the Ritter Forum what happened to this graft after 10 years. And she came, 10 years follow-up. I wanted to see, because I didn't see her. She moved to Saudi Arabia. And 10 years post-op, this is what happened. Amazing. If you need the connective tissue now, you can have a good donor side, okay? So you have an extra donor. You have 3 tuberosities this patient have. So this is, and I learned this from Howie. Howie told me, today, if you have to do it, don't do it as a laser. You just have to flap and take the internal connective tissue grafts. You cannot leave it, take it from the outside. And this is after 10 years. This thing keep on growing. It's crazy. I mean, it kept on growing. Implant's still there, but, she has a pregnant gingiva. So if anybody here has a recession, I want to do graft, I have a good donor for you, all right? So this thing keep on growing. I have many cases like this after 10 years, really, it kept on growing. So if you choose your connective tissue graft, don't choose the tuberosity or a free anagami smile patient, because this will turn into white. In these cases, probably better to choose a connective tissue graft internally from the palate with thick one, rather than choosing a free that will turn into white, and then, on a gummy smile patient is not really fun. And this is her smile before or after. The other good news, Raquel, she started doing lip filler, which was really amazing. I love it. I do lip filler too, not because I like lips, just to hide my complications or hide the missing papillas. So this is something that you should learn too. Sometimes it helps, Botox and filler for dentists. So this is the case how we started, and this is the case 10 years post-op. Another case, what if you place your implant too close to the teeth? This is, again, another friend of mine, oral surgeon. He was partying hard the night before, and then the next day he had this implant to place. And then he placed the implant, of course, in less than 1 minute, because, Imad knows, oral surgeon like to be really fast, right, Ricardo? Super fast, boom, boom, boom. And the challenge he was doing, if he can place the implant in less than 1 minute, which he did. But this is the result. And then he sent me the case. He said, Alain, you are the papilla man. Can you grow some papilla for me? And I was like, okay, ready? It's lunchtime, no? But you took 7 minutes from my time, so I have 7 more minutes, okay? Give me 4 on the top of 7. Thank you. Okay. So this is, when you look at the challenge in this case, implant is placed too close to the teeth, to the tooth next to it, too close. And then when you look at the treatment option, you can always remove implant. And if I have to see the case today, probably I would remove the implant and start all over again. But this patient didn't want to go through this. So she said, can we do something about it? I said, yes, we can try, because I'm coming to Dubai, so I want to see my friends. I showed them what happened if we can try. And this is what we did. So I placed the healing abutment, not the cover screw this time, because I wanted to try to hike the tissue in a higher position. And I took a customized connective tissue graft. So we always do our connective tissue graft today customized, trying to build the connective vertically and horizontally. And this is the connective tissue graft placed in a position where we suture it and put the implant to sleep. And then we wait 3 months for the maturation of the soft tissue. And after 3 months, we just connected the abutment. We did the gymnastics to find, this is an old case, 2013, to find the right abutment, because we did not have the right angulation. So we had to struggle to get her to the right angulation. And this is how we started, and this is where we finished. We were able to have an acceptable result, probably not the best outcome, but it's an acceptable result from where we started. And I did, this patient, she's still in Lebanon, and she's still working as a dental medical rep for an implant company. So I always see her. And I brought her back again 10 years after. This is the healing. After 10 years, she's still there. The tissue's still there. And then just last week, Giorgio brought her for another follow-up, 12 years follow-up. And this is a 10 years follow-up. She's still there. And this is 12 years follow-up. She's still there. Not the best implant, but yes, she was okay. She was happy to maintain what we have with the bad implant placement. So let's jump to the last case. What if you place your implant in a buccolingual position? Well, if you place your implant in the buccolingual position, and this is a very common if you're doing immediate loading, At the time when I started doing immediate implant placement, my teacher at the time used to tell me, go to the palatal bone, go to the palatal bone. And when you go to the palatal bone, this is what happened. Your implant is too far to the palate, so it comes out too buccally. And this is an old lady. She's one of the, 3 generations, they come to our practice. She's almost 79 years old. And she has this titanium smile. And her daughter, she's telling me, can you treat this titanium smile for us? I said, yes, we can. Because when you look at this case, take a CBCT, look at the implant, completely off, right? No buccal bone, no soft tissue. On the 79 years old, are you going to remove the implant and try to do all this again? Take us through bone graft, soft tissue graft, 2 years of treatment, many surgeries. Are you going to do this? No. So what can we do? Well, again, we come up with a list of complicated challenges. What are the challenges that we have? And based on these challenges, we come up with the treatment options. And the treatment options, in this case, we decided to try to save the implant. And how do we try to save the implant? Well, first we have to remove the crown, make it an under contour crown, adjust the abutment, and try to graft it. And this is what we did. We flapped it. We no need to place implant. This is a bone loss on the implant, not a peri-implantitis. So the surface is not infected. And we slap it, take the tuberosity again, my favorite place, my happy place. You take the tuberosity, place it, suture it around the implant, and then suture the flap on the top of it. And then always you have to cover the connective tissue graft if you try to choose this technique. This is a few months healing time, and this is almost 2 years healing time. So in one surgery, we were able to save this patient hassle and treatment and, 6, 7 appointments and money. And this is where we started, and this is where we finish. Now, the question is, if you look at the studies today, this is a recent study that talks about buccal implant placement. Buccal implant placement, my friend, if you place your implant too far to the buccal, there is a 14 times more chance, 14, that you will have a buccal implant recession. So why placing the implant too far to the buccal? Just place it in the safe green zone. And this is the case the before and after, and this is the case before and after. In one surgery, we were able to improve the quality of this patient's life because when she's smiling, she was showing the titanium, and now with just one surgery, she's okay and happy with the smile. And when you look at this recent article on placing the implant too far to the buccal, 15% of our patients today are suffering from this. 15. So almost 2 patients out of 10, they have this issue. And we could have avoided this by placing the implant in an ideal position. To come to the conclusions of this chapter, well, always when it comes to complications, the best thing to do is prevention. If you can prevent it, this would be the best, your best bet. This is the most predictable treatment when you prevent complications. 2, well, you have to select the right case. You have to select the right patient. You have to know your skills and know your limitation and know what you can do and when you cannot do it. So it has to be our decision as well. 3, well, of course, today with the world of digital, I mean, this is not a magic bullet. It's not going to place the implant for you. It's going to just help you. It's a tool that will help you to do the right thing, to place your implant driven by prosthesis. You have the CBCTs and the guide today, it's a must. I always have guides on my tray. Sometimes I use them, sometimes I don't, but at least I have them. And I feel more secure when I have them. 3, well, always when you place your implant in a 3D positioning, you have to respect these 3D positioning. Stay away from the tooth 1.5. Place your implant 3 to 4 millimeter from the future gingival margin, and always toward the palate. If you have no bone, my friend, send the case to Portugal. They visit Porto. It's a lovely city. I love it. And then they can do bone graft at the same time. So don't place the implant if you have no bone. And if you don't have soft tissue, go to Brazil to Ricardo. He's the king of soft tissue, right? And then you can always graft the soft tissue, enhance the quality, the quantity, so you can have a better aesthetics. Always temporary, and this one will send it to Spain, to Ramon, my friend Ramon, to do the perfect ideal prosthetic contour in order to support the prosthesis. And in cases where it's really advanced, like we have an advanced bone loss, very bad implant placement, well, I would like to play the role of hero sometimes, but this is too much. Case like this, look at this implant, man. This is a young guy, a really young guy, 25 years old, And when you look at the CBCT, the implant is really placed where the bone is, not where it's supposed to be. And in these cases, don't try to be a hero, just remove the implant. Remove the implant because, you cannot do it. And when you look at this, look at the angulation. This is crazy. This is not ethical today. This is malpractice, placing the implant in this position. So in these cases, unfortunately, we have to take these out. And I did like Raquel. I removed the wisdom tooth here, and at the same time, take the bone. I learned this from you. And then place the implant in an ideal position, do the GBR at the same time. And imagine you have to take these patients again through bone, soft tissue to rebuild everything back up. And this is, in these cases, the best thing to do is just to remove the implant. Last slide. So in these cases, my friend, really, complications, imagine how much patient they have to go. And the last one, number 8, is always what we do is teamwork. And I'm not here alone. I'm here with a big team of 13 dentists. We are all different specialties. We sit and think together and we brainstorm to give really what is the best approach to our patient. And today's education is really important. You cannot be successful in your practice. You can be a good dentist, but if you want to be a great dentist, you have to learn. And I still learn every day. In 2 weeks, I'm going to take a course myself. So we always have to take courses. And today you have really the best lined up speakers in the world where they can teach you these kind of things. To finish up with this quote, success, is the result of a good judgment. You do your good judgment, you're successful. The thing is the good judgment is the result of what? Experience. You have experience, you have a good judgment. And experience comes from where? Experience comes from bad judgment. Right? So we all learn from our mistakes. I hope today I was able to share with you some of my mistakes and other colleagues' mistakes. Thank you for staying late. Thank you. It's a great, great pleasure. Sorry for the...
Excellent lecture.
Thank you.
Let's go to the center.
Yeah.
The relatives. Center.
Center.